Welcome, Dr. Gary. Thank you so much for joining us.
Oh my goodness, Carolyn, it's so good to see you. Thank you for having me. Thank you all for joining. I'm just watching these numbers climb and people from really across the world who are tuning in to talk about this important topic and get some information. So, thanks again.
Absolutely. We're so thankful to have you here. So, to start us out, and I know you're just a wealth of knowledge and will show us some more in your slides, but just give us a little bit of a background on what lymphedema is and the risk for those specifically with a breast cancer diagnosis.
Sure. So lymphedema relates to fluid retention or fluid backup within the lymphatics. And I'm going to show you some slides and a little diagram about it. But if you think about your lymphatic system like a spider web system under the skin, a very thin lattice, almost like lace, right?
Mm,
That drains infection and inflammation, proteinaceous fluid, so non-blood, non-bodily saliva, things like that, right? And so every place in the body drains to someplace else. You get a head cold. It drains
mm,
to the glands in your neck, and you get the swollen glands. Well, the breast and the arm drain to the glands or the lymph nodes under the arm. And so understanding that helps you to understand why if you do a surgery and you make cuts and you remove parts of that lymphatic system, you could end up with a backflow or a
mm.
swelling as a result of interrupting with that drainage system. I tell my patients, you mess with the plumbing, you can get back up in the pipes, right?
Yes. Absolutely. And that's very, very helpful. So, speaking of you talking to your patients, as a breast surgeon, what do you typically communicate with your patients about lymphedema prior to surgery?
I typically will talk to my patients about the risk of lymphedema, the low risk of lymphedema associated with what we call the sentinel lymph node biopsy.
Mm,
When we look to do a surgery and when cancer is invasive, and meaning it broke out of where it started, the next question a patient will ask is, well, how do we know it didn't go anywhere else? And so at the time of that surgery, we will give a little dye injection and it'll go through the lymphatics to the first place that breast drains to, which is typically under the arm. And we'll do a small incision and remove that very first lymph node. And so the risk of lymphedema in most modern studies is around 2 to 4%. The slide that I'll show you has about 5 to 8%. And it really depends on the number of lymph nodes you remove, the size of the incision. But we talk about one, the risk of lymphedema being small. Two, the benefit of knowing your lymph node status because there's a risk benefit ratio. And three, ways to assess for and then ways to mitigate the risk of lymphedema. How do you know if you have it? Who are your resources? Making
mm.
sure that there's like a preoperative appointment to talk with our therapist about that so that you feel well informed postoperatively.
Great. That's really, really helpful to hear. And obviously, you, as a standout all star breast surgeon, are starting these conversations with your patients. Not everyone might have that with their surgeon. And some people may be on the other side of this lymphedema journey, meaning that they're already dealing with this. And so I think segueing into your slides and taking a look at how we can monitor for lymphedema and what we can do if and when it appears is going to be really, really helpful. So let's jump in if you feel comfortable to those slides, and then we can get some questions from the audience after you're done your presentation.
Absolutely. And I know someone put in there, I think it's important to note that lymphedema can be present if you don't have surgery. You are absolutely correct in that anything that blocks lymphatics can cause lymphedema, and that can include cancer cells blocking those lymphatics.
Mm,
And so we'll talk about some of these things, right? So this picture on the top right is a diagrammatic depiction of the skin, and there are layers to the skin, and underneath and beneath and between those skin layers, there are lymphatics. This is that lace system, that doily or lattice system that I was telling you about, and you can see these little dots, right? So this system of lymphatics is what drains, and when you look at the breast drains to multiple places. Most commonly, it'll drain to the armpit, or we call it the axilla. And there's levels to this axilla. There's level one, level two, level three, getting up into the shoulder, into the neck. And then there's these internal mammary lymph nodes as well. So anywhere where there are lymph nodes, right? This is where cancer can spread because breast cancer typically spreads, we call it lymphatogenous or lymphogenous. It'll spread through the lymphatics as opposed to through blood or through other means like other cancers can. So when you get this accumulation of lymphatic fluid, it's either because these could be blocked with tumor cells or because we've disrupted this pattern. And that swelling is not only associated with the breast, but it can also with the armpit, right? And the arm, but it can also be associated with the breast. And so when we talk about who's at risk for lymphedema, 5% or so, I quote 2 to 4% of patients may develop lymphedema in their lifetime from the small procedure, the sentinel node biopsy, where we inject either around the areola or around the tumor to find out where's the next station. I'm a Philly girl. So if the train leaves the station, where's the next station? And we actually remove that at the time of surgery. For some operations, for some patients, we have to end up doing not only the sentinel lymph node, but removing additional lymph nodes. And that's called an axillary lymph node dissection. So when we do an axillary dissection, we're taking all the level 1 and 2 lymph nodes, that can increase the risk of lymphedema up to 20%. And I talk to patients about that. These slides, this particular diagram was taken from MGH and Harvard, and they want to, make sure that people understand that the vast majority of it relate to surgery, relate to radiation, and I'll show some information about that. And there are some risk factors, right, like being overweight. But some of those other risk factors have to do with the things that we, as a medical community and as treatments, things that we do to try to reduce the risk of cancer recurrence. So some of the taxane-based chemotherapies, right? Elevated BMI, removing all those lymph nodes, radiation, regional lymph node radiation. When you get radiation to your breast, and not only to your breast, but your armpit, right, and your shoulder, that regional node radiation can increase the risk of lymphedema because it really does shrink and cause those lymphatics to become more fibrotic and sometimes more inflamed. Increasing age is also a risk factor for lymphedema. And it's one of the reasons why, we're starting to look at, well, who needs axillary surgery, right? Who needs radiation to their axilla? And there's a lot more shared decision making regarding all those things. And you can see here that when we have to take all the lymph nodes and give radiation, so that's advanced stage disease, stage 3 disease, for example, where the cancer has left the breast and gone to your axilla. In those instances, you have to get radiation not only to your chest wall or remaining breast tissue, but also to that shoulder and to the back and to the clavicle up here. That increases the risk of lymphedema as well. So a later stage diagnosis is one of those things. Somebody asked a question in the chat, really about the frequency of lymphedema and timing of lymphedema. And it depends on the surgery that you had. And if you have an episode of lymphedema, you are at elevated risk for a recurrent episode. It doesn't mean that it will happen again, but we do see that once you have experienced lymphedema, it becomes a chronic management condition. Patients who've had sentinel node biopsy are higher risk later on, they're saying 3 to 4 years post-surgery. And this is why it's important for, at my cancer center, we see patients twice a year, really for that first 5-year mark. And they do have some appointments with our lymphedema prevention program so that we can identify, who's likely to be at risk, who's got some questions, issues, concerns, whose measurements might be different so that we can try to preempt that. And when we talk about screening, I know we're going to get into a more nuanced conversation of some innovation in lymphedema detection, but there are different ways that we screen for it. In my institution, we have a program, lymphedema prevention program, a physical therapist who really specializes in the detection and management and patient counseling around lymphedema. And a lot of that, you may be familiar with this arm measurements, right? You can see she's got a tape measure, and they're going to measure the forearm, the wrist, the forearm, and the upper arm on the affected side as well as the unaffected side. At Harvard, they're using a pyrometer measuring the arm volume. There are other ways as well, right? So we talked about the circumferential measurements. We talked about a little bit volumetric. You'll see in some institutions, I think more globally than here in the US, they may submerge the affected limb in water and then measure the displaced water volume. We're going to talk a bit more about bioimpedance, not so much the spectroscopy. Actually, yes, we will talk about that and the SOZO system that is useful to measure the actual fluid volume in the body. So we're getting much more precise with how we're measuring and detecting lymphedema. There are imaging techniques that we can use. We can give a dye into that lymphatic system, and surgeons are more and more becoming familiar with and routinely using lymphoscintigraphy to try to visualize the lymphatics, identify blockages, identify the drainage pattern of the upper extremity so that we can try to reduce the chances of our surgeries even causing lymphedema. CT scans, I don't think really provide a very good view of the lymphatics. It can show you fluid within the tissues, and it usually is incidental findings with a CT scan. But things that you might notice, pitting edema test. When you press in, does the thumbprint stay? Does it leave an indentation? Ultrasound could be used. Fluorescence could be used. So there's lots of ways to start to look at the lymphatics. But the reality is that early lymphedema doesn't always have signs. And so when you go to your doctor to talk about these things, or if you're having a consultation, like a preoperative one, you're with a family member and they're talking about all the risks of surgery. Some surgeons should mention lymphedema and they should talk about the program they have for that. And if you say, well, what are some of the signs? Well, it could be swelling of the arm or hand. And you can see that, sort of stage for stage, right? Early stage lymphedema, this is a 3% increase in swelling. How difficult is that to see? Compared to an 11% increase. You can see a little bit more fullness here, right? Compared to a 33% increase. And so swelling of the arm or hand, heaviness in the arm, your jewelry is starting to get a little bit tighter. And I do counsel my patients about the immediate postoperative IV fluid causing swelling, right? So after surgery, you wake up, let's say you've had a mastectomy or something, and your fingers and your rings might be a little tighter, but you might have gotten more fluid than you normally would consume during that surgery. So in the immediate 24, 48, 72 hours after surgery, it's typically not lymphedema. It's typically related to fluid shifts and surgical fluid hydration. Okay. But as you are in your recovery, tingling in the arm, the hand, the digits, and it's important to note that lymphedema can occur not just in the arm and the lower extremity, but we can see lymphedema on the chest wall, in the breast, in the hand, on the back, right, of the side of the body that was treated for breast cancer. And so if you have thick skin and swelling in any of these areas, those are early signs of some lymphatic congestion. Okay, so I don't call it quite lymphedema. I call it, maybe some lymphatic congestion that could ultimately lead to a more chronic lymphedema. So, important to know it does not always have signs, and that if you are offered an opportunity to meet with a lymphedema prevention therapist or a program, you really should consider it. Because I think as you build out who's on your team, you've got your surgeon, you've got your oncologist, you've got all these wonderful folks, having therapists who can tell you what to expect, who can help you to assess for these things, who can give you recommendations regarding exercises and even compressive therapies. Like that's an important component of your care, not an afterthought. So if you're offered that opportunity to meet with them, I do recommend that consultation. And it can be a scary one because, this on the bottom right, this is a scary thing to happen. And you'll see folks who have to end up wearing compression garments and things, but knowledge is power. And if it's one thing that we have learned, it's really that when you know what to expect, you don't know what to expect in a cancer journey, but when somebody can tell you either what to expect, what to watch out for, things to look out for, or things to do to help improve them, that's an empowering stance. So some of the later signs of lymphedema, right? Because we kind of talked about the earlier ones, but late signs of lymphedema really would be things like having difficulty with your range of motion. If you can't make a fist and close your fingers, right? You really can't flex your wrist or your arm. If your skin is becoming increasingly thick, there's a term for that called elephantiasis, right? Your skin's starting to look like elephant. If you have poor wound healing, recurrent infections, these are all signs of later stage lymphedema. And these are reasons to see not only your breast surgeon and your oncologist, but you may be referred to a plastic surgeon to look at some surgical management of these things. The management of lymphedema, more often than not, starts with conservative therapies that are something like we call it complete decongestive therapy. And there's two phases, the active therapy and then the maintenance. The active therapy is, what a licensed lymphedema specialist is going to do. And in my facility, we have them on the ground floor, and they will meet with you. They will assess, do you have things like axillary cording? Do you have changes in the volume and the volumetric measurements of your limbs? Do you have decreased range of motion? And then they're going to teach you how to do exercises at home so that you can do them at home during the maintenance phase. And this can be an uncomfortable phenomenon, right? And so I do counsel my patients to make sure that they are looking at multimodal pain solutions, including things like, can I say acetaminophen? I can say acetaminophen right now, acetaminophen, Tylenol, right? Ibuprofen, heat and cool compresses, things of that nature. And so it's important to make sure that you are not limiting yourself, but that you work with a therapist who can tell you what's safe for you to do at home. All right, so exercise. I have heard patients say they tell me not to exercise. Exercise is one of the best things that you can do before surgery. I call it prehab. After surgery, right? You can do your rehab at home or with a therapist, but it helps to promote healthy weight. It increases and encourages circulation, and that's important. Now, that being said, I do not advise my particular patients to do rigorous upper extremity exercise immediately after surgery because seromas can form. A seroma is a collection of fluid in the space that the body is made. If I remove some tissue, the body sees a space and it will try to fill that space with fluid, and you can end up with a bit of a golf ball underneath the arm. And that seroma may have to be either massaged, it may need time, or it may need to be drained in the office. I may have to do a procedure and remove that fluid. So I don't advise rigorous upper extremity like ellipticals, mowing lawns, vacuuming floors, etc., for the first 2 weeks after surgery. But thereafter, I encourage my patients to advance their activities as they're tolerated. Skin care, right? Monitoring for infections, making sure that you are moisturizing your skin, applying moisturizers daily, and being thoughtful, especially if you're under consideration for radiation. You want to be careful about oil-based moisturizers prior to radiation. But before and after, in your morning, in your evening routine, it's really important, I think, for cancer patients in general to pay great and close attention to your skin because all of the things that we do can really dry out that skin. There are compression therapies, and you can find experts who can help you to manage the short-term swelling through compression sleeves, like the arm sleeves, additional gauntlets and stockings for the hand. And those are more for long-term management. Patients may have to wear them daily for 3 weeks, for up to 3 months even. Advanced pneumatic compression therapy, these are compressive, sort of like the squeezers when you go right before surgery, or if you go to, you sit in one of those lovely massage chairs at the store and they kind of squeeze your ankles and make their way up your legs. Those are things that can help mimic the contraction and encourage the fluid movement. And then manual lymphatic drainage is a hands-on technique, and this is something that, families can learn to do. You can work with a therapist, and it isn't all massage and relaxing. It can be a little bit rigorous, right? It doesn't have to be, but sometimes it can be. But there is a certain and specific technique to lymphatic drainage and lymphatic massage, and I do encourage my patients to find those therapists and to utilize those services. As I mentioned, there are stages of breast cancer associated lymphedema. And you can see stage one, maybe a little mildly swollen, but you kind of can't tell. I mean, unless you are really looking to see, are there decreased veins in the hand, right? Like this one, you can sort of see. You can see the vasculature here in the wrist extending into the forearm that now seems to have faded away. So maybe just a bit of mild puffiness here compared to stage two, where, if you elevate it, right, the swelling goes down and you press on it, you may see a dent. Stage 3, this is really clinically elevant, and the swelling doesn't get better with elevation. And you press on the area, and it no longer leaves a dent. And then stage 4, you can see again this sort of elephantiasis picture where the skin looks like wrinkled like an elephant. You can see sometimes nodules or warts, extensive scarring. The skin is thicker, it's much more tough. And, these are people who have really decreased range of motion and quality of life issues. And so, always, 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 our goal is to find, manage, and prevent lymphedema, but to treat lymphedema as early as possible. When we talk about, well, what are we doing for this? There are doctors you may talk to who say, oh, the risk is so small, don't worry about it. But we know that the risk can be great, and the sequelae, right? The quality of life issues can be tremendous for a person who has lymphedema. And so surgeons, especially along with our plastic surgery colleagues, are starting to do more to investigate the causes of lymphedema from our surgeries and then look at ways to either reconstruct, right? Like this is a study that came out of Harvard. They're injecting a dye into the lymphatics and they're looking at harvesting and replacing some of the lymphatics. We call it a lymphovenous bypass, right? Because what we're finding is that, let me go to this picture. We're finding that there are individuals who are at increased risk for lymphedema based upon the lymphatic drainage. And so now we can give dye and we can actually map and see, okay, does your lymphatic only go one way and it goes down the arm into the hand, or do you have multiple patterns of drainage from your armpit? Are you less likely to get that lower extremity swelling because you have multiple drainage pathways as opposed to just that one tricipital pathway where if this is disrupted, all the fluid's going to back up? And so that's called reverse lymphatic mapping, right? Axillary reverse lymphatic mapping. And we now can inject a dye that will travel through the hand, through the arm, into the axilla, and then we can inject a separate dye where we can now find the target lymph nodes. So we can see the ones we want, the ones we want to avoid. And so many academic institutions are starting to do this so that we can then avoid the post-surgical lymphedema because we now are able to see which lymph nodes we need to target and which ones we need to avoid. This is still somewhat, I'm going to call it experimental because it is not the standard of care. But I'm showing you this because I want you to know that despite the lower risk of lymphedema, because of the quality of life issues associated with it, we are continuing to invest in, ways to identify who's at elevated risk. What can we do to mitigate and manage that risk? And then what can we do on the diagnosis side of things to make things and make life easier? So, you cannot prevent lymphedema, although we do call it a lymphedema prevention program. It really should be called a lymphedema risk reduction or management program. And one of the most important things you can do is to maintain a healthy weight. It's to make sure that, your blood sugars are, if you're a diabetic, your blood sugars are regulated, your A1C is within normal limits because chemotherapy is a risk for lymphedema. Diabetes is a risk for lymphedema. Smoking, tobacco use is a risk for lymphedema, and obesity, of course, right? So those are things that you want to try to manage the best you can. Avoiding cuts in the affected arm. This is something that you do want to be considerate of, but you should not tailor your entire activity to these risk precautions. And what I see most often in some patients is that they go to that lymphedema appointment and they come away with a list of do nots. Don't do this, don't do this, don't do this. You can't fly, you can't try, you can't garden, you can't get your cuticles cut, you can't do, and then they don't know what they can do. And there's a lot of fear surrounding that. So yeah, wear gardening gloves. That's important. Insect bites, you do want to limit yourself and wear sunscreen, wash your cuts, avoid, allowing your skin to crack, wearing an SPF, etc. Those are important things. But there is no evidence that blood pressure readings, blood draws, injections are going to cause lymphedema. We do tell patients to preferentially use the other arm. But in patients who have bilateral surgery and patients who have, venous access issues, if you need to use the limb, right? You should avoid blood draws or blood pressure only if you have been diagnosed with lymphedema or have a history of lymphedema. And I think this is important to note. There's strong evidence that exercise does not cause lymphedema. It actually improves lymphatic drainage. It improves circulation. Exercise is our friend, and it is one of the main ways to mitigate against cancer-related fatigue and side effects. So definitely do exercise. If you're not sure what to do, how much to do, how much to push yourself, that's where you need to see a physical and occupational therapist. There is no evidence that lymphedema is caused by airplane travel. However, right? I tell my patients, you fly into Myrtle Beach, I'm in Pennsylvania, you don't necessarily need to wear a sleeve. You fly into Scotland, guess what? You probably should wear your compression socks. You may consider a compression sleeve for your upper extremity, more for your peace of mind than anything, right? Because you don't want to be concerned that you have lymphedema. You should stretch your arm early and often. And this is based on, surgical literature. I think the lymphedema literature may still suggest that, these are necessary things. I think that they are important tools in your toolkit. Flying long travel, that sort of airplane compression, right? And in the cabin, that cabin pressure can push fluid down into the lower extremities, just as we see it in the arms and the hands, right? So you fly and you notice that your ankles are getting swollen. So it's not a bad idea to consider. But there isn't evidence that if you don't have lymphedema, that flying on a plane is going to cause it. That's the point of this slide. Saunas and hot tubs. I get a lot of questions about this. There is no evidence in the medical literature, right, that saunas and hot tubs are going to increase or cause lymphedema. There is one study that suggests that it may play a role in the development of lymphedema, but again, these are not really peer-reviewed, randomized controlled trials. I mean, I think if somebody wants to do a randomized controlled trial of people in hot tubs and saunas, sign us up, right? But be careful with things like folliculitis. You shave your legs, you get into a hot tub, that is a setup and a nidus for infection. So that's really my concern regarding those sorts of things. And the last slide I'm going to show, and this really leads into our next topic, is that we are starting to see precision, just as we have precision oncology, right? Precision drugs and tailored regimens. We're starting to see some precision in symptom management of lymphedema. And one of my good friends is the chief medical officer for a company called ImpediMed, and they have a SOZO digital health platform where you can get your LDEX score. This is a much more empiric measurement, not just sort of, we measured with a tape measure, your wrist, your forearm, your upper arm, but really, what's the fluid doing? What are the fluid shifts in your body? And how might that predict your lymphedema risk so that we could then develop a regimen for you even sooner, even before you start to see, that swelling and everything. So I think it's important for you to know that there's a lot of hope on the horizon, that there are more precision ways to measure this, to manage this than ever before. And it is never too late for you to have a lymphedema appointment. So you can meet with a lymphedema specialist at any time in your cancer journey. It doesn't have to be, I missed it during my preoperative, appointments, and now I guess I can't see a therapist about this. This is always something that you can bring up. So definitely focusing on your meals, your movement, your mindset, getting that body moving, paying attention and learning to listen to your body. And, American Cancer Society is recommending, there's a lot of movement, 150 to 300 minutes per week. But the studies show, even if you can do 30 minutes a day, even if you can only do 5 minutes of something that's sort of high intensity, right? You're in front of your TV or you're watching this webinar and you're walking in place, right? And you get your 2 water bottles and you're moving your water bottles up and down. I don't know if you can see my arms here, right? This is moderate intensity, right? You walk a little faster, that's high intensity. Even 5 minutes of that a day can help to decrease the risk of recurrence, can increase circulation, can increase endorphins, can help from a cardiovascular standpoint, can decrease the risk of lymphedema occurrence as well. So definitely get moving, walking, dancing, those dance parties, hiking, biking, swimming, resistance, weights. Yes to all of this. And this goes against some of the earlier teaching around lymphedema. We want our patients to move. We want you to lift weights. We want you to use resistance bands. We want you to stand, 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 right? Sedentary sitting is the new smoking. So we're asking everybody to really increase the amount of daily movement and activity. Oh gosh, so I snuck in a picture of my farm because that's what we focus on here in Pennsylvania, the meals and movement, the mindset, because that's the stuff you can control, right? And so I'm going to stop sharing slides and I gotta want to take some questions, I think. We got some good activity going on in the chat here. I love it.
Oh my goodness, Dr. Gary, that was so informative. As a nurse, but on the medical side of things, I don't get all of this information from surgeons. And so I feel like I learned a lot through what you shared. So many great questions also. I've been trying to kind of bucket them so we can hopefully hit a couple right now before we bring Keelin on to share her experience. So a common question has to do with just briefly the definition between cording and lymphedema and if there's a connection there.
That's a great question. Cording is a manifestation of inflammation along the lymphatics, right? And
Okay.
so think about it like your breast drains into your armpit and then your arm goes down your arm. So guitar strings, if you can pluck and feel something that sort of feels like a guitar string in your armpit, that's cording. Axillary cording is an increased risk factor for development of lymphedema, but it doesn't mean you're going to have lymphedema. It means that there's inflammation in the lymphatics that are in your armpit. And so one of the things to do is to start seeing that therapist early, right? Because they're going to do some exercises and stretching. It's not going to feel good. This is not like the nice smooth massage, but they're really going to give you some exercises to work out, right? And to break up, as they say, break up those cords.
Mm.
So chronic cording that is not addressed can absolutely lead to lymphedema. So if you have it, if you see it after surgery, you must address it. Bring it up with your surgeon. If your surgeon's like, oh, it'll go away, bring it up to your navigator. Tell your navigator, I might need to see a therapist about this.
That's really helpful. Thank you for explaining that difference and the risk factors. Another couple questions came in about just location of lymphedema. Is it only in the arm? Can it be on the other arm, the breast, the legs?
Ooh, so lymphedema can be anywhere in the body where there are lymphatics, right? And the whole body's connected like a subway system. That being said, if you have surgery in your armpit, you're not likely to see lymphedema in your lower extremity, like in your leg.
Mm. Hmm.
So, you can see though, and this is something that we don't always address and recognize, lymphedema in the breast, right? And it usually manifests as thickness along the inferior aspect of the breast. That skin can be thicker, kind of like a grapefruit. You can see
Hmm.
that pitting, etc. So lymphedema can happen in the breast. It can happen in the arm. It generally will not happen on the other side. It's usually the affected side.
Okay.
Okay, so it's very rare to do a surgery on one side and see swelling in the other hand.
That's really helpful information. And you just answered a whole bunch of questions there. So I appreciate that. Next one, we had a couple questions about compression devices. So, two individuals who have lymphedema want to know if they need to use their compression device daily. And then someone who does not have lymphedema wants to know if they should proactively wear a compression sleeve, etc.
Okay, let's see. So let me start with the second question first.
Mm-hmm. Okay.
So the second question was if you don't have lymphedema, should you wear a sleeve?
Yes.
And the answer is no. No,
Okay.
you do not have to. Now, the only caveat I will add is if you're going on long flights overseas, et cetera, if you plan to be on, plane distances, and talk to your doctor and your team about this. But I generally say if you would wear compression leggings or compression socks on a plane, it's not a bad idea to wear a compression sleeve or garment for your upper extremity. So I say, flights really over like 6 to 8 hours. Those are
Mm-hmm.
considerations. Um, the second question is the pneumatic pumps. They typically
Mm-hmm.
are used daily, okay?
Okay.
Because that can help to manage the swelling and the symptoms. And what people don't realize is that the symptoms are often subtle, right? You look at, water and ripples and waves along a pond, you may not see a big ripple, but the fluid may truly be moving. And so when you use that device daily, it is helping you to manage not just the swelling you can see, but the swelling that could be building up over time that you don't see until it's swollen. So yes, I do recommend daily use. And again, talk to your therapist about how often and how long you have to use it for.
That's very helpful. And I think kind of explains the nuance of sometimes we can't see this. When you showed that picture of the
Yeah.
3% difference in fluids, we can't see that. And so if someone's using that and not really seeing the difference, well, it might just be because we're preventing and making sure that we don't have a larger problem. And I'm assuming that now that we have some better technology like that SOZO device, we can actually get some more specific readings. And I know Keelin will share her experience with that as well. Another question that I think you may have mentioned briefly in the slides, but can lymphedema be painful? We have some individuals who are still experiencing a lot of pain in the breast and axilla. Obviously, that can be multifactorial, but could it
Mhm.
be a sign of lymphedema?
It can be, and it is, as you said, multifactorial. So there's a couple things there. One, after axillary surgery, the nerves that run from the armpit to the skin and that give you that sensation under the arm here can be cut. And so a lot of times you can feel sort of numbness here. You can feel very hypersensitive here. That hypersensitivity is not necessarily a sign of lymphedema. That has more to do with the cutaneous or the skin nerves that were cut and that are regenerating during your healing process. When you feel tenderness in the breast after radiation, radiation itself can cause some sensitivity in the skin and can cause lymphedema, right? Meaning fluid retention within those skin layers. And as that builds up, that does many times feel tight. It can feel tender. So yes, pain is more of, I'm going to say, a consequence of rather than a
Mm,
symptom of lymphedema. But yes, if you're having unexplained swelling, tenderness, things like that, you got to make sure, one, you get checked out for things like inflammatory breast cancer. Do not
mm,
assume that it is lymphedema. Make sure that your doctor has ruled out inflammatory breast cancer, which can manifest as very thickened skin, red skin. We call it peau d'orange, peel of the orange, right? If you have orange peel skin and it's new to you, that's something to not make an assumption about. So I would say yes, it can result in tenderness. It can be a symptom of, especially later stage lymphedema, but there's a couple other reasons why you might have that tenderness as well.
that's really helpful. Thank you.
Mhm.
I'll ask one more question before we bring Keelan on. Do you see a difference in lymphedema risk with the type of reconstruction that someone chooses?
Hmm. Oh boy. That's a great
It's a tough
question.
one.
It is a tough one. So, and I'm gonna say I see it in general, less lymphedema in breast conserving surgery because more of the entire lymphatic pathway is left intact, right? If you do a
Hmm.
lumpectomy and you take out one or two lymph nodes as opposed to a mastectomy and removing, 8 to 10 to 15. I saw somebody in the chat said they had, whoa, 41 lymph nodes removed. My
Hmm.
goodness, right? So that risk is much, much higher. I think the difference between lymphedema with implant-based reconstruction versus like deeps and autologous flaps using your own tissue, um, I don't know of any studies that have really looked at that. I'm just not aware of that literature. But what I can tell you is that doctors are now trying to figure out how to reconnect lymphatics in those instances. So if you're going to have that deep reconstruction, which oftentimes is delayed, or you may
Hmm.
had a failed reconstruction, right? Maybe your implant got infected or it just didn't do well. And now you've got to do the autologous moving the fatty tissue into the breast. They're starting to look at can we map the lymphatics and can we decrease lymphedema for those patients? So I would say there's probably a slightly higher increased risk of lymphedema when you have the deep inferior epigastric perforator or the deep flap reconstruction.
Hmm.
And I noticed that somebody in the chat asked about swelling in the legs, right? So there are lymphatics in your abdomen as well, right? Into the groin. Generally speaking, though, when you see people who are like on chemotherapy treatments and that could be a protein issue. So
Okay.
seeing swelling in the legs as a result of breast cancer treatment may have a lot more to do with your protein stores than cancer blocking the lymphatics. But it certainly is a possibility. But be mindful of the fact that everything isn't always lymphedema. And making sure that you're getting a good protein. That's why I brought this up, because making sure that you are having, as best as you can, excellent nutrition that focuses on reducing that swelling, making sure that your heart is okay. You don't have congestive heart failure. That's another reason that you might see increased fluid in your lower extremities, increased tightness in your fingers and all. So, there's sometimes some other reasons besides lymphedema.
And I think that's incredibly important to highlight. And a lot of the things that you have mentioned stem back to go talk to your provider, have them do some tests, right? Do you need a skin punch biopsy? Do you need to see a specialist to work this up to see, is it lymphedema? Is it potentially something else? Because it could be so many different things. Let's bring Keelin on though, because I would love to have her kind of share her experience as a patient advocate who has some experience with lymphedema. So, Keelin, give us a brief intro of yourself, and then I have some questions for you.
Sure. Thank you, Dr. Gary. That was super insightful to see all of the diagrams and really understand what is happening. But my name is Keelin. I'm 28 years old. I was diagnosed with stage 3 breast cancer at age 26. So 2 years ago, I moved home and received treatment in Northern Virginia. But I've since moved back to Charleston, South Carolina, and I'm managing my lymphedema with a mix of a physical therapist and at-home management, and just navigating sort of the survivorship of breast cancer, especially at a young age.
Thank you so much for joining. You are a wealth of knowledge, and we have worked with Keelan previously and really appreciate her insight. So, Keelan, tell us a little bit about what your care team shared with you about lymphedema prior to your surgery.
Sure. So my breast cancer was isolated on the right side. So I knew, especially after the first biopsy, we knew that it had reached the lymph nodes. So I was educated very early with my care team on not only the risk, but my care team did a very great, thoughtful, they took the time to educate me on lymphedema, not just rush into all of the risk and possibilities. They really educated on what it meant and shared diagrams with me so I could fully understand what it was, what I could look out for, and sort of how every step of my journey might, impact the risk of lymphedema. I did undergo 2 surgeries, and had a handful, a little over, I think, 12 or 14 lymph nodes removed out of my right armpit. So did the auxiliary lymph node removal. So I was really educated first. Along with the education, they went proactively, took the initiative to take a baseline. At my hospital, they did have the technology to measure the amount of fluid in my arm prior to my first surgery. So really, the education and then taking baseline and measurements was super important and imperative, with my journey. So they shared just, they took the time before this first surgery, really educated me on what to look out for. And then before my second surgery, we looked at other, techniques that we could apply possibly to surgery to lower the risk. So I did complete a lymphovenous bypass surgery during my second surgery. And then following that surgery, we knew I was going to go into radiation. So, the conversation was ever changing and really, you know, just catered towards what is next on my journey and what to look out for. So we took it in like small chapters, I think, because it was something that was ever changing, with my just like navigating what my journey looked like.
That is incredibly helpful. Dr. Gary, anything that you would add? I know we talked about this briefly in the beginning, but that you kind of prepare your patients for in advance.
Yeah, I do try to counsel about sort of what to expect after surgery. But even before we get there, I really try to make sure that they understand the relationship between the breast and the lymphatics, the fact that, based on the number of lymph nodes we remove and a lot of other factors, the risks for lymphedema, but just communicating with me early, letting me know what's going on so that we can start to address these things early. And I love that you said, you got a lymphovenous bypass, right? We are able to really kind of reconnect the lymphatics, which drain into the bloodstream. Somebody asked that question in the chat, and I
Hmm.
typed an answer. The lymphatics ultimately drain into the bloodstream. And so one of the ways that we look at and treat lymphedema is that we're able to take these little tiny vessels that are, I mean, tinier than, vermicelli noodle, right? They're spider webs, 4 strands of hair thick, and really start to combine them back into the veins. And that allows for that drainage to go back into circulation. And so, there is hope. And I think that's what I really hear from your message, Keelan, is that there is a lot of hope around managing and living with lymphedema when we know early and we speak up about it, we assess it.
Definitely.
So helpful. And that actually segues really nicely into my next question for you, Keelin. Um, and I have prefaced this, but did you experience lymphedema symptoms post-surgery?
Yes, I did. I think it's important to note that, it to Dr. Gary's presentation, there's different stages. There's it can be subtle or it can
Mhm.
be, really noticeable. For me, I was really proactive in listening to my body. Like most of us, when we are going through a journey like this, I knew I had to really listen to my body and know that no symptom was too small to bring up in conversation to my care team, across, all members of the care team. So I began noticing just a sense of like, for me, it was an unusual sense of bruising, sort of a bruising feeling, on my right arm, little acts of movement that I didn't expect to make my arm feel tired were, was feeling tired, like reaching for something in the microwave or the repetitive motion of like folding laundry. There were things that right after I would do actions like that, my arm would feel really heavy or like tired. And I knew the risk. I just was expecting, swelling or my jewelry to stop fitting. So it was something that I really had to tune in and be like, okay, something's not quite right. I'm just feeling really tired, heavy on this arm. And then, the sense of bruising without showing bruising. I later learned that it was an inflammation and, cording being developing across a certain area of my arm. But those symptoms, I immediately communicated it to my whole team via my chart, or if it happened to fall on an appointment, I brought it up immediately and just really advocated for myself that something didn't feel right. Can we go back to the measurements? Can we go back to, the technology that we have and really try to identify um, what could have possibly changed over the time of my first measurement, between the first and second surgery, et cetera. So those were some of the symptoms I experienced. It was mostly, just the repetitive movements became really exhausting for my arm. And yeah, I was just really expecting, those images and, what you learn about and look for a completely swollen limb. But in my case, that wasn't the initial symptom of my lymphedema. It really became like internal feeling.
I think that's really important to highlight as well, that this can look and feel so different. And I know obviously Dr. Gary highlighted some of those early symptoms, but the bruising and advocating right away with your care team, especially to get some updated measurements, I think is paramount. Dr. Gary, anything to add to that?
I think the only thing I would add is that the classic symptoms may not be your symptoms,
Mm.
right? And so this is, what she's saying exactly is that something felt different. It felt off for me. It felt like, just too much fatigue for too little movement. I did a few things, all of a sudden it's just heavy and something is off for my level of activity and my norm. And that's sometimes hard for doctors to hear because you may not fit the classic mold of these sorts of things, but bringing it up and noting when did it happen? What made it better? Is this every time you vacuum the floor? Okay, and you put your arm up and it gets better. Now I'm getting a picture of what's going on. And so you becoming the investigator of what's happening with you and bringing as much information as you can to the table is really, really helpful so that we can help to advocate for you and help to tease out what might be going on.
That's great to bring up. And I think we always kind of highlight that you are the expert of your own body. And so if something does not feel right to you, it is definitely worthwhile to bring these up. So Keelin, after you brought this up to your care team, kind of what were the next steps for you? I know you've had quite the journey.
Right. So we went back to my baseline measurements. We retook all the tests that I underwent prior to my surgery. I was able to identify lymphedema mostly through the Sozo machine that measured the fluid. We were able to identify that my measurements were nearly symmetrical across both limbs, but it wasn't until that fluid machine was able to measure and record that the amount of fluid in my arm had fluctuated up on the right limb. So with that understanding, that, there indeed was more fluid in the arm, we had to act, very quickly. And that was, once we identified that, my care team, I found a physical therapist. They referred me to a physical therapist. That was the word I was looking for, refer, to a physical therapist who was a specialist in lymphedema management. So, that those appointments have very much changed from the very beginning of when I was diagnosed with lymphedema. My first few appointments, as Dr. Gary explained, it wasn't super pleasant. It wasn't that lymphatic spa feeling of an appointment. It was really working my arm and identifying the cording and identifying, those blockage areas and how the, arm felt different week over week. And really just learning, what can I do? What should I be doing? Where do I begin? And I think a physical therapist was the best person to teach me little stretches, send me home with bands so I could do exercises, the simple sleeping, the way I slept, I lifted my arm up while I was sleeping to, just, it was a lot of trial and error, I would say, to figure out what was helping and what felt good for me. I did immediately do some compression garment measurements, and I ordered a hand glove, which I still wear today, as well as a compression sleeve, because I'm active. I'm in office. I'm, sitting, trying to get up and move every day, but I had that daily wear. It was really trial and error in the sense of like I got compression sleeves and then I got at home wraps. Like I would wrap my arm at night. I would on bad days add foam. Sometimes that wouldn't work one week and I'd say, okay, this isn't quite working. How do we, change it up? What other stretches should I be doing? Um, and then we would add, different I definitely in my walks now, I do movement over my head. I like do these over my head to get the movement. I, learned how to do manual lymphatic drainage. But I would say, I see a physical therapist every week, and that appointment looks different every week. It's not the same. Things can change overnight, or even in hours. Like I woke up this morning, my hand wasn't quite swollen, but a few hours later, I added this glove. So I think my physical therapist really just educated me with at-home management. But at my stage, I needed that extra management with a physical therapist to really work it and like push through some of the cording and scar tissue and be that extra two hands on my arm. And it was great to also, do progress reports with her. What weeks, week after week, what have I been doing that maybe has reduced the measurements or reduced the Zozo machine fluid measurements. So I think the physical therapist was really crucial to me. And then always communicating my own progress of how I feel to her so we could record it in the notes and then, that can be communicated with the larger care team. So I think I did a lot and it was a lot of trial and error. It didn't come easy. One garment didn't solve, it for me. It all has been super different week over week.
And I think it's really important to highlight. And it's also important to highlight that you were diagnosed 2 years ago and you're still having, obviously surgery wasn't 2 years ago, but you're still having weekly appointments with your PT. And so, as Dr. Gary mentioned, this is a chronic condition and you're still working at it every week. And so important to highlight that. And then hopefully with some of these new technologies, we can get to a point where it isn't so chronic. But thank you for sharing that. Dr. Gary, anything to add as far as kind of some of those post-action steps?
Yeah, I think, always asking your team, what do I look for at home? What should I do? When am I safe to do things? And the answer is not always going to be fixed because everybody heals differently. And so it really is monitoring how I feel. You know what? I'm 2 weeks out of surgery and now I'm able to. Well, I tell my patients immediately after, we're shrugging, right? We're shrugging shoulders. We're moving our neck. We're keeping, because everything's tight. You're all kind of drawn like this, and that impacts your circulation. It impacts your muscles. It impacts your pain. And so making sure that you are doing things immediately post-operatively to stretch as best as you can and to gradually, slowly increase those movements and everything is very, very important. Many of us have toolkits, we have pamphlets and books that we give out that helps people to know week one after surgery, what are you generally safe to do? And so I think having that sort of kind of a primer, and if your doctor doesn't have one, LBBC's got resources, right? They got resources aplenty of what you should do as far as your postoperative your movement and things to watch for at home. We might think about doing a little toolkit kind of checklist or a little symptom tracker of some sort, actually might be kind of helpful to create. But yeah, I think that's it. And just kind of knowing that it's normal to feel uncomfortable. It's normal to feel a little tight. But as you are now 3 weeks, 4 weeks, 5 weeks, 6 weeks out of surgery, hmm, you know what? There's some things I need to maybe talk to my doctor about because I'm still having these symptoms. They haven't gone away yet.
I think, yeah, that's absolutely accurate and so important. A really quick question for you, Dr. Gary, and then I have another one for you, Keelin. As far as monitoring, whether it's with the Sozo machine or with, something simpler in the office, how frequently, if someone has lymphedema, should they be getting that monitoring?
Mhm. So Sozo is typically done quarterly, I think. So like every
Okay.
couple of months. It can be more depending on, what the concern is, but generally speaking, at least twice a year. But I see many practices doing it on a quarterly basis.
Okay, great. Keelan, obviously you've tried many, many things. Is there one thing that you have found to be most helpful for you? And I know you said it changes every week, so might not be an easy answer.
Yeah, I think the regimen that I have found that works best with me right now is, finding that balance between comfort and efficiency. I think for me, there were some night garments that I tried. Sleep is really important to me. I enjoy my sleep. Um, and I think there are some nighttime garments that were just too constricting. It just was really uncomfortable. So for me, I found that, you know, while those might be super comfortable for someone else at night, it was most comfortable for me to just manually wrap my arm and add foam, like a little foam wrap on
Hmm.
the hand or the forearm where I needed that extra pressure to sort of push the fluid up. So I think, these have become things that I just carry in my backpack or have in my office in case, throughout the day it's starting to feel a little heavy. I can wrap this and just do it, quickly. It wasn't the first time that I could do it on my own. I had help. A physical therapist had to teach me how to properly wrap this. But now I'm pretty good at wrapping it on my own. But this is something that really, I can't have too many of these around my house. We are always rolling them, it feels like, or finding little clips in our rooms in our house to keep them intact on my arm. But these have been super great for me. If I know I'm going to be active or traveling, I will use something like if I'm traveling, I'll wear this with the full sleeve, or if I'm playing any type of sport, I'll definitely, lean into these garments, like the Juzo garment. Um, but I'd say these two have become things that I sort of interchange. I recently have gotten a new knit garment that seems to be a little more comforting at night. And it's having lymphedema it's timely. It's a management. It's a routine that you have to carve out time. And you know, for me, it was another appointment. It was, I'm too tired to do this, but I think I really just learned the importance of I feel a lot better when I do some of these. So, carving out those extra 5 to 10 minutes to just do this at night and then take it off in the morning and rewrap it. So I definitely would say these wraps. There's a lot out there. I have definitely tested a lot. I think I more noticeably, like in the last few months, it's become less of swelling in my arm. It's sort of moved down to my hand. I, don't know why, but I've learned how am I going to manage that, swelling in the hand better. And I just also educate myself through different platforms and channels or like blog posts. So I, went to my physical therapist and I said, it's, swelling in my hand. It's getting hard to hold or write. And, it's uncomfortable. What else can we do? Because what I've been doing is not working anymore. So we've tried K-tape on my arm, just sort of wearing tape down my fingers and then, wrapping over to the wrists. And that has seemed to work for my daily, my days in my office when I'm at the computer all day. So it's really, every day's different. I think it's just it's time management, giving myself the time to know that I have to deal with my friend lymphedema, and it might be different today than it was yesterday. So really just preparing and having that toolbox and all of the different ways of managing it, because it certainly changes throughout days and activities. So yeah, just learning and giving patience. I think for me it was really frustrating. It was like, I'm doing this for 2 weeks and it's not working. Or,
Mhm.
it's something that you just had to be really patient with yourself and give yourself the grace that, you're gonna have to do trial and error. And it's something, just finding that balance of comfort and what feels good to you, because it might not be what feels good to me. Yeah, I think there's a lot out there. So willingness to try and, optimistic that hopefully you can find your balance between management and comfort.
That's so helpful. Thank you. And I think it's also so important to note that these physical therapists that specialize in lymphedema, this is what they're seeing and working with every single day. And so they can help you build that toolbox even better than some of your other providers. Dr. Gary, anything to add there?
Yeah, Keelan brings up a really good point, which is that it isn't always the same, right? So knowing what to look for means knowing you're normal, because sometimes swelling could be in your upper arm, it could be at your elbow, it could be, this is not, it jiggles a little bit, but now something is going on here. Or hey, now it's in my wrist. And so I think it's important to know, as you think about and understand the lymphatics, the body is connected. Right? It's an entire network. It's a subway system, if you will. And so there can be different manifestations of lymphedema. So paying attention to that and finding ways to manage that. And someone else put in the chat, I think it was, I don't want to call anybody's names during the webinar, but really great advice on when to wear your sleeve and gauntlet. A lot of people do it during sleep, when they elevate, and that way during the day, they kind of notice that things fill up, and at night, they sort of push it all back into circulation. But it's going to be different for everyone. And also nutrition, decreasing the amount of inflammatory foods and looking to, there's no one right diet or anything for, certainly for cancer, risk reduction and risk of recurrence. We've talked about things like the Mediterranean diet, but an anti-inflammatory diet, foods that do not cause or create more inflammation in the body, are things that can definitely help with the lymphedema process and with that management. So yeah, really important things to consider.
Thank you for that. Dr. Gary, a few other questions here. We had two questions about, well, one was red light therapy and then similarly infrared saunas with lymphedema. Any advice on avoiding or using those things?
Still experimental, right?
Mm,
So there are some early studies looking at infrared light to support and reduce lymphedema. It makes sense that it potentially could, like light therapy should probably be a thing. But again, there's not a lot of long-term studies on it. So I would say you got to talk to your team about
mhm,
it. In general, things that help to decrease inflammation and decrease toxins, things that help detox, etc., are not a bad thing. But hot tubs, for example, someone else put in the questions, they got
mhm.
stage 2 lymphedema. If you've already been diagnosed, those might not be the right things for you. So definitely talk to your team about them. But things that help to increase circulation, decrease the amount of toxins in the body, it stands to reason that there could be some benefit there. But again, very experimental, and I'm not endorsing them.
Okay, thank you. One last question for you, Dr. Gary. Someone asked, they have lymphedema. It's really hard for them to get to treatment. It's very far away. It's not super accessible. Besides their own comfort and kind of aesthetic of having that lymphedema, is there an actual medical reason that they should want to get rid of the lymphedema, whether it's from a cancer perspective or just moving the lymph, or is it really just their own comfort?
No, there is a medical or clinical detriment to having lymphedema, right? Because it can become more progressive. Stage one lymphedema is a nuisance, right? You can live with it. You might notice that, okay, I don't see the veins as much. Stage two, all right, my arm's heavy and I just can't, I can vacuum, but I can't vacuum and garden, right? But as you get into stage three and stage four lymphedema, and it's not to minimize the symptoms of any of that for sure, but as you get into stage three and four, you run the risk of venous stasis, ulcers, you run the risk of infections, your skin starts to change, the integrity can change, and you're at increased risk for infections that can cause really health issues, and your quality of life decreases. So, I think it's something to be under consideration for, to monitor for. If it's well controlled and compensated, you don't necessarily have to continue to pursue some treatment for it. But somebody should be kind of checking in with you about it to make sure that it isn't becoming more progressive. This is, again, that chronicity of the relationship with your oncology team, not just your surgeon, not just your oncologist, but all of these therapists who help to make sure that your survivorship, is as full and robust as it can be, because lymphedema is one of those things that can kind of chip away at your survivorship and, be an issue bigger than we'd like for it to be. So having a good plan in place, checking in with your body daily, having some tools to address it and feeling good about that plan is all part of your survivorship care plan.
Thank you so much. That is so helpful to hear. And I think, closes this out really nicely with the information that you've both shared with us. So thank you so much, Dr. Gary, for sharing your expertise, and Keelin for sharing so much of your personal story and your journey. This was a great discussion with a lot of helpful information.